Let's move on to our last speaker before lunch. Always a tough spot to be in, but I have no doubt that Kelly will take care of it. So you guys met Kelly yesterday, just to review her pathway. She did most of her training in London. She did a master's in health research at MAC, and then trained for a couple of years in Los Angeles County in their fellowship with Dr. Dimitriadis. Kelly has many, many, many talents, and I think you'll see her in the decades to come as a force not only in Canada but across the world when it comes to acute care surgery, trauma, and emergency general surgery. Probably most importantly, she just had her first baby, so congratulations, and thank you for talking to us about DCD.
Thank you very much, Dr. Ball, and again, it's a privilege to have the podium. I am mindful that it's the last talk before lunch, so I'll be as expeditious as I can be. We're going to talk briefly about transplantation and then really an overview of what donation after cardiac death is, how we do it, and a little bit of data on how common it is both in Canada and the United States, and some future directions. And before I start, I'd like to acknowledge Dr. Ian Ball, one of my colleagues, and our local OPO here in Ontario for providing me with some of the data that I'm presenting today in some of the figures. Solid organ transplantation has really been around since the 1950s. In the early 1950s, the first kidney transplant occurred between identical twins, and since then it has really exploded in terms of its utilization within our countries. And interestingly, we're talking about DCD as somewhat of a novel therapy today, or a novel concept today, but really the first organs that were transplanted were in fact from donated after cardiac death donors. And what they found in that early experience, probably because of a lack of advancement of transplant science and also immune therapy and general care at that time, was the outcomes really were very poor. And so in 1968, when Harvard put out the brain death criteria, we shifted towards brain death criteria, allowing organs to remain perfused until the time of harvest, and outcomes improved. This increased the donor pool substantially, and patients were doing better. So after that time, there was a significant shift. DCD was not something that was discussed, at least in the Western world, and outcomes improved, with donation after brain death becoming standard. So if that's the case, why are we even having this conversation? Well, this is Ontario data. Really what I want you to focus on, the top line is in green, is the number of patients on the wait list for organs in our province. The blue line is the number of transplants, the red is the deceased donors. What's important from this slide is there's a significant gap. We have many more patients who need organs than organs that we have for them. And this is American data, and the line of patients who require transplants aren't even on here, but what you can see with this is over time we are certainly increasing transplantation. This is, like I said, US data. So because of that, because there are more patients who need organs and we can't seem to meet the demand with the current donation after brain death, there's been a resurgence of this concept of donation after cardiocirculatory death. And really to increase the number of donors that we can get. And I put this slide up, which is interesting. If I was giving this talk in Japan, it would be the exact opposite. So in Japan, and even in some European countries, Spain is really a leader in this field, donation after cardiocirculatory death is the mainstay, and donation after neurologic determination of death would be a novel concept for them. So within our context, DCD is emerging within our area. And so what's the major difference? Well, between neurologic determination of death and donation after cardiac death, really the main difference is the time or the way in which death is defined. And with what we would consider traditional organ donation, death is defined after cessation of brainstem function, meeting predefined brain death criteria or even extended criteria, whereas donation after cardiac death occurs when donation follows death defined as irreversible cessation of circulatory and respiratory function. And in general, DCD progresses with cessation of life-sustaining therapies, and we'll talk about when that might not be the case, to death diagnosed after cessation of cardiorespiratory function, and then rapid recovery of the organs after cardiorespiratory arrest. We'll go into this a little bit more. can't talk about DCD really without talking about controlled versus uncontrolled DCD donors or the donation process. And just as an overview, controlled DCD would be what most of us in North America are fairly familiar with, where you identify a patient who has non-recoverable injuries, and a plan is put in place for withdrawal of life support. And the cardiac arrest occurs, and the patient then proceeds towards brain death. It's somewhat of a planned process. This also could potentially be considered the case if patient has been declared brain dead, but then cardiac arrest does occur. Uncontrolled DCD, which is much more common in Europe, for example in Spain, is unplanned. So these are patients who are brought into hospital dead, who have unsuccessful resuscitation, or who have cardiac death in the hospitalized patient. So very different, and most of what I'm referring today is controlled DCD, just because that's what we're using mostly in North America. In Transplant International just recently, this was published just clarifying the controlled versus uncontrolled terminology and the circumstances which lead to each of them. The biggest thing you need to understand is that controlled DCD is just that, it is controlled. Within the confines of not knowing exactly when death will occur, we can make plans. In uncontrolled DCD, the time that the organs wait from the time of cardiocirculatory death till harvest is prolonged up to 45 to 60 minutes, and that's really the major difference. So just to highlight the key differences from patients who undergo neurologic determination of death, the determination of death obviously is different, but what does that mean for us practically? Well, practically what that means is that the opportunities for organ optimization and the time between determination of death and organ retrieval differ. In the case of neurologic determination of death, it is much more controlled. You have the opportunity to, first of all, potentially optimize the organs more, and also to have the organs continue to be perfused until they're retrieved. Whereas in DCD, there is a lack of perfusion, this so-called warm ischemia time that occurs from the time that the patient is pronounced dead till the organ is retrieved. And that has implications we'll discuss further. So who then should be considered as a potential donor for DCD? Well, first you need to identify that the patient has what is deemed non-recoverable injury, and obviously there are many things that go into that. However, unlike patients who are potential for brain death donors, the brainstem reflexes remain present, and you have no real anticipation that the patient is going to progress to brain death. As I said before, the controlled circumstances around brain death determination really make it sort of the preferable option in North America, but if that's not the case, this is a very good option. And so if your patient is someone who is potentially a candidate who has a non-recoverable injury, and you know that it's within the wishes of the patient and their next of kin, which we'll talk a bit about more in a second, you can progress down the pathway of considering DCD. And what does that look like? Well, if the physician agrees, similar to patients who undergo donation after brain death, there would be a period of organ-specific evaluation, and that differs depending on your organ procurement organization. It's very specific, but the organs potentially that could be donated are evaluated. And specific to DCD, you could consider a trial off of the ventilator. The trial off the ventilator helps us to understand how likely this patient is to progress in the time frames that we need them to progress to be a viable candidate for donor. However, that being said, there are many relative contraindications to the trial off the ventilator, as you can imagine, in relatively unstable patients, and so this certainly is not required in all patients who are progressing towards DCD. I want to pause just for a second to talk about the decision makers, because I mentioned them briefly on the previous slide. But anytime we're talking about donation, I think it's important that we remind ourselves of the importance of the loved ones of the patient who is going to be considered a donor. In this particular case, there obviously needs to be very tight coordination between the clinical team caring for the potential donor and the physicians who are going to be retrieving those organs. Now, that being said, it is extremely important that there be dissociation between those two teams with respect to the decision making and also with respect to the procedure for DCD. I will highlight again, and not the focus of this talk, that as physicians, when we're coming to a circumstance where we think our patients may be organ donors, that conversation is best had by someone who is removed from the situation, someone who works in your organ procurement organization, or some other person within your institution who can have that in an unbiased fashion. And we know that that increases not only retrieval rates, but certainly makes our families feel much more comfortable, and for me, myself also. And recognizing that for the reasons we're going to discuss from a practical standpoint, this discussion actually oftentimes is more complex than for patients who are going to be donors after declaration of brain death. And to help that, the WHO, I know you can't read it, but it's there just to trigger you, has this critical pathway for organ donation. It really helps us identify the terminology and helps us to understand why patients may not become a donor. And I highly recommend that anybody who's going to be speaking to families about this, about organ donation, take a look at this, because it can provide a lot of useful information. So assuming that your patient is identified as a potential DCD donor and you know that in fact this is the pathway that you're going to undertake with them, what can you do in the care of your patient to optimize the chances of success? Really most importantly is to continue to treat the patient as you would in preparation for the process of DCD. And what does that mean? Well, it means that we're doing the best that we can to make all potential organs retrievable. So maintaining organs at their optimal level of function by maintaining euvolemia, hemodynamic normality when it's achievable, and normothermia will be the best that you can do to help those organs withstand the stress that they're about to go through. With respect to withdrawal of life support and how the process occurs, I've already mentioned that really should not be influenced by the transplant team or the OPO, and that with respect to how the patient is managed through their end-of-life process, whatever you as an institution or you as an individual physician are comfortable with is how the process should proceed. Again, I mentioned the family and loved ones of the potential donor. There are a lot of things that go into this process, and that should be certainly taken into consideration. So if there are particular religious or cultural practices, if there are particular wishes on the part of the family or next of kin, those need to be taken into consideration in your planning. But there certainly is a lot of planning that goes into the withdrawal of life support, particularly in the case of DCD. The first is timing, and that sort of ties into the next point. As we've mentioned in the scenario of DCD, there is a period of time that the organs are ischemic, and the so-called warm ischemia time. And the goal is to try to minimize that so as to maximize potential organ function. So the timing is extremely important, and that leads into the idea of where do you do this? Do you withdraw care in the intensive care unit with a plan for rapid transfer to an operating room once death has been declared, or do you do the actual withdrawal of care within the operating room? It's a complex decision, and certainly there are many institutional factors that go into it, but significant planning, and most of your institutions who do DCD will certainly have a protocol in place for this. Proximity to the OR makes a big difference. If your ICU is right across the hallway, it may be more feasible than if you have to take an elevator in the ICU. But again, recognizing that the family may want to be at the bedside, those are discussions that need to be had, and certainly beyond the scope of what I can tell you to advise you on in 20 minutes. I can say, however, that members of the procurement team should not be present at the time of withdrawal of life support for ethical reasons. So the process of declaration of death is really not that different than when we normally do it, except for the time factor. And your local hospital will have a policy in place. This is ours. In our institution, it may change. Essentially, the life support is withdrawn, and the attending physician is present to witness no signs of life for 5 minutes, although ours is a little bit longer. A minimum of 2 minutes is what is required. And for us, that's no palpable pulse, no measurable blood pressure, and no successful breathing efforts, and we require 2 physicians to confirm death based on these. And again, independent from the procurement team. I can't emphasize enough that when DCD is being undertaken, contingency planning is key. Unlike donation after brain death, there is a reasonable, not insignificant chance that the patient may not progress in the time frame that allows for successful organ recovery. And it's really, really important that everybody involved in the care of these patients and potential donors understand that. The family needs to be aware that there's a potential that despite their wishes and the wishes of their loved one, we may not be able to proceed successfully with organ transplantation or even organ recovery. So do the staff. So if you have the patient in the operating room for DCD and they don't progress in the appropriate period of time, what's your next step? What does the family get to come back in? Do you take the patient back to the ICU? Where do the next steps occur? Again, it will differ depending on your institution, but these are things that need to be thought of prior to initiation of DCD. A few other considerations that are unique to DCD, different from donation after brain death, are when do we initiate some of the things that need to be done to improve the organ retrieval and organ success rates. So cannulation, when does that occur via the femoral artery and vein? Many will argue that cannulation prior to withdrawal of life support would lead to improved organ outcomes. It allows you to flush the cold preservation solution rapidly after declaration of brain death, and I think that's fairly standard in most institutions. What's a little bit more controversial is anticoagulation. While most consider it standard, some raise ethical concerns that giving a high dose of anticoagulants to assist in the ultimate organ retrieval and function could potentially hasten death. Now that's been discussed frequently, and again, most centers now do give it prior to withdrawal of life support or right at the time of withdrawal of life support. However, it's something that needs to be understood within your local community. Just a word on the actual process and terminology, and obviously this differs depending on the organ. I put this up from Transplant International, not to go through the specifics, but in terms of an education tool, this one I think is excellent. It just shows exactly the process and the steps that you're going to go through, particularly highlighting in red that period of no touch, that period of between to the time that death or we think we've determined death and that waiting period, which can be difficult when you have teams on standby waiting to retrieve organs. But something along these lines can be shared with those in your institution who are going to be involved in the care of these patients to better understand the process they're about to undertake. And for example, for a patient in whom you hope to retrieve the liver from the donor, the process looks something like withdrawal of life support, declaration of death, possible cannulation if that wasn't done prior to withdrawal of life support. The liver is rapidly explanted and cold perfusion flushed, and transplantation occurs after that time. As you can imagine with this functional warm ischemia or warm ischemia time that we talk about, the idea is to minimize the amount of time that the organs are warm but not perfused. And so it's discussed significantly, this idea of super rapid recovery techniques, the idea being that everybody is as prepared as possible prior to the withdrawal of life support, and that your goal is to attain rapid aortic cannulation and venting of the vena cava, and even cannulation of the portal system in situ. Again, specific to the organ that's being recovered, however, things that need to be thought about ahead of time. Even further, some centers discuss post-mortem ECMO, putting patients on extracorporeal membrane oxygenation after death to restore flow of warm oxygenated blood to the organs. When you read about it in the literature, this is really done for patients with marginal organ status and has been best studied in renal transplantation. And I would not by any stretch of the imagination call this routine, but it certainly is something that can be considered. So we've mentioned that outcomes might differ from donation after brain death, but what does that actually look like? And really it depends on the tolerance of the organ for ischemia. There's tons of work, I would say, going on into this right now. So this is at the current state, but I anticipate that this is going to change. So for some organs like kidneys, probably the best studied, probably the outcomes are fairly similar to patients who have been declared after brain death. And pancreas, there's a very small study that suggests that they likely are equivalent. However, compared to brain donors, or brain death donors, the outcomes are likely worse for liver. Heart and lung are in parentheses because their tolerance for ischemia is so low that the number of organs transplanted is really quite minor, so we don't really know the answer yet. There is a significant body of literature going on with respect to how to optimize the outcomes of patients who proceed to liver transplantation after DCD, and so this is changing, and hopefully within the next few years we might move that to the other column. But nonetheless, we can say that compared to patients who progress through the donation after brain death pathway, with patients who go through donation after cardiac death have fewer organs transplanted per candidate donor for many reasons. As we've already talked about, the potential donor may not die within the time frame allowable for transplantation or retrieval of those organs, and the organs, because of this warm ischemia time, are much more likely to be deemed unsuitable. So because of that, within our culture anyways, donation after brain death remains the preferable option when it's feasible. And what does DCD look like in North America at present? So this is Ontario data again, and this is percentage of donors by donor type. I want you to focus on the green bars, which is standard criteria donors for neurologic determination of death. So by far and away, the vast majority remain donation after neurologic death. However, the purplish grayish bar, that one is donation after cardiac death. And you can see that it's not an insignificant portion of the organs that we're getting in Ontario now. And this is American data. It only goes up till 2006, but similar. So the high blue bar is brain death standard criteria, and the reddish bar is cardiac death. So a small proportion, but certainly gaining as we move through the years. And this is Ontario data reflecting total DCD donors over time. It's just numbers, but what it tells you is what we're seeing practically, which is that the DCD is increasing in frequency in our institutions. And in fact, in Canada in 2005, there were almost no centers that were even considering DCD, and now every transplant center is at least considering DCD. And in the United States in 2015, 16% of organs came from patients who were declared dead after cardiac causes. So where do we go from here? Well, I think that talks like this and other discussions, I think, are extremely important. We need to make people aware that DCD exists, both our providers and also the public, so that it's not a surprise when this gets brought up. In Europe, presumed consent opportunities have led to a significant increase in the number of donors, and certainly something that could potentially be explored, the idea being that everyone is presumed to be a donor, so they'll crash them to retrieve the organs if they come in from out of hospital dead on arrival. And as we've already mentioned a little bit, trying to improve the outcomes of the organs retrieved after DCD and minimizing the functional warm ischemia time. There are ex vivo machine perfusion techniques that are being investigated, particularly in liver, that have very promising initial results. And so I anticipate that that's going to become a much more mainstay part of the process of DCD. So in summary, DCD represents a resurgence of an old idea, but has significantly increased the donor pool for a very large number of patients who still require organs. Difference from donation after neurologic death are significant, and they definitely require lots of consideration ahead of time, and the importance of communication amongst those who are going to be involved cannot be underscored. Progress is being made to identify potential donors and improve outcomes, and this is an area of great study right now, and more work is certainly required. Happy to take any questions. Thank you.